Hi, everyone. We're ready to get the next session started. That was a terrific session. Thank you to our speakers for that. So next we have Dr. Do-Youn Oh, who is a professor in the Division of Medical Oncology at the Seoul National University Hospital. You know, after 13 years of gemcitabine and cisplatin being the frontline standard for cholangiocarcinoma, we now have a new frontline standard. And we're very lucky that the presenting author who presented this work a couple of weeks ago at GI ASCO is going to be presenting the work for us today. It's going to be recording and it'll be streaming. Thank you.
Hi everyone, I'm Do-Youn Oh, medical oncologist in Seoul National University Hospital, Seoul, Korea. Thank you for inviting me to this wonderful meeting. Today, I will talk about TOPAZ-1 trial for biliary tract cancer patients. This is my COI disclosure. The developments in systemic therapy of biliary tract cancer is shown here. Since the advent of AC22 data, so gemcitabine and cisplatin has been adopted as standard of care at first-line biliary tract cancer patients. Since then, so far we haven't had better regimen compared to gemcitabine and cisplatin at first-line setting in near 10 years. In terms of targeted therapy, recent days we have seen some progress. Today, I will talk about immunotherapy in biliary tract cancer. The first immune checkpoint inhibitor tested in biliary tract cancer was pembrolizumab in KEYNOTE-028 and KEYNOTE-158 trial. KEYNOTE-028 trial enrolled only PD-L1 positive patients, and KEYNOTE-158 enrolled patients regardless of PD-L1 status, and both trial enrolled heavily treated refractory population. The ORR in KEYNOTE-158 was 5.8%, one-digit number. In KEYNOTE-28, ORR was 13%. Anyhow, the responder from both trials, their response was durable, but the overall survival was ranged 7 to 9 months. So the efficacy is modest. And nivolumab in refractory population in biliary tract cancer showed a very similar efficacy. So ORR was 3.3%, and PFS 1.4 months, OS 5.2 months, and that efficacy was not that well correlated with PD-L1 status. Nivolumab PD-L1 inhibitor monotherapy also showed a very similar efficacy data in refractory biliary tract cancer patient. ORR 4.8%, PFS 1.5 months, OS 8 months. So we can say that immune checkpoint inhibitor monotherapy in advanced stage refractory biliary tract cancer patient, efficacy in general is modest. So to improve that efficacy, several strategies have been tested. One of these strategies is to combine immune combination. The example is durvalumab and tremelimumab combination, CTLA-4 inhibitor. So ORR 10.8%, a bit higher compared to durvalumab monotherapy. PFS quite similar, but OS 10 months, a bit longer compared to durvalumab monotherapy, and 1-year survival rate 29%. So another effort is to combine the immune checkpoint inhibitor and cytotoxic chemotherapy. So nivolumab and gemcis chemotherapy was tested in 30 biliary tract cancer patients at first-line setting. The ORR 36.7%, and PFS 4.2 months, and OS 15.4 months. So compared to conventional gemcis data, a bit higher ORR, a bit longer overall survival. We've also tested a similar concept in biliary tract cancer patients using durvalumab. We conducted phase 2, a study named BT's first Mediterranean study. This study composed of 3 different cohorts, but basically this study was not randomized trial. we just wanted to test 3 different strategies to combine cytotoxic chemo, GEM-CIS in this case, and immunotherapy, durvalumab and or tremelimumab. So cohort 1 named GC followed by GC-DT, we used GEM-CIS cytotoxic chemotherapy alone at first cycle. And after second cycle, we add durvalumab and tremelimumab on top of GEM-CIS. Cohort 2, called GC-D cohort, we use gemcitabine and cisplatin and durvalumab combination, the triple combination, since first cycle. And cohort number 3, we called GC-DT cohort. We use GEM-CIS and durvalumab and tremelimumab for drug combination since first cycle. So you can see the different schedule across 3 cohorts. Across all cohorts, we did the baseline tumor biopsy. And after 1 cycle of treatment in each cohort, we did follow-up tumor biopsy here. And at the time of disease progression, we did tumor biopsy again here. This is patient disposition data, 32, 49, and 47 patients who were enrolled in each cohort. In terms of safety population, 32, 47, and 47. In terms of efficacy evaluation population, 30 patients, 47, 47 were included. This is patient demographics in the efficacy population. 30 patients, 47 patients, 47 patients in each cohort, and altogether 124 patients. Median age was 64, half were male, and 58% had equal performance 0, 42% equal performance 1, and 45%, 55% had initially unresectable disease, and 45% recurrent case. In terms of primary tumor location, actually we included ampulla cancer too in this phase 2 study. 53% had intrahepatic cholangiocarcinoma, and 24% gallbladder cancer, and 11% extrahepatic cholangiocarcinoma, and 11% ampulla cancer. There are quite few patients with hepatitis B. This is treatment response waterfall plot data. So across cohorts, you can see the good tumor response, including the red CR case in each cohort. This is one of the examples of the CR case enrolled in cohort 2, GEM-CIS plus durvalumab cohort. The CBD cancer patient at baseline CT scan, you can see the multiple metastatic lesions. After 2 cycles of GEM-CIS plus durvalumab, the first response evaluation CT scan showed a complete response. And follow-up PET imaging also showed that metabolic CR. This is a summary of tumor response. So in each cohort, ORR was 50%, 72%, 70%. And altogether, total 124 patients, ORR was 66%. And those responses were quite durable. So response duration was 9 months, 11 months, and 8 months in each cohort, and altogether 9.8 months. PFS in all patients, median progression-free survival was 12.1 months, 1 year. When you look at this PFS data across cohorts, cohort number 1, 12.8 months, number 2, 11.8 months, number 3, 12.3 months. So you can see the consistent PFS graph across cohorts. In terms of overall survival, median OS was 18.4 months. And for each cohort, cohort number 1, 15 months, number 2, 20.2 months, And number 3, 18.7 months. Again, we can find very good overall survival data. In terms of adverse event profile, in general, the regimen was quite well tolerable. So even there's no big difference across cohorts, so 3 combination cohort and 4 drug combination cohort, very similar. And majority of grade 3/4 adverse events were hematologic toxicity. So in terms of non-hematologic toxicity, there was quite few cases with grade 3/4 adverse events. When you look at the expression pattern of PD-L1 at baseline tumor biopsy specimen, you can see the tumor cell PD-L1 pattern and immune cell PD-L1 pattern here, all patients here. And we also present this PD-L1 pattern according to primary tumor type, intrahepatic, extrahepatic, gallbladder, AOV. In terms of tumor cell PD-L1, we couldn't find a big difference across tumor subtypes. However, in terms of immune cell PD-L1, we could find more immune cell PD-L1 expression in extrahepatic cholangio and ampullary cancer. We correlated the clinical outcome according to this baseline PD-L1 expression in each cohort. This is cohort number 1, GC, followed by GCD2 cohort. Baseline PD-L1 expression status, tumor cell, immune cell, and all together. And efficacy parameter, ORR, PFS, and OS, no difference. This is cohort number 2, GC, gemcitabine plus durvalumab cohort. Again, PD-L1 status was not correlated with efficacy parameter. This is cohort number 3, GC, gemcitabine plus durvalumab plus tremelimumab. Again, baseline PD-L1 status was not correlated with efficacy. We looked at the change in PD-L1 status from screening biopsy to after 1 cycle biopsy specimen in each cohort. So interestingly, after 1 cycle of gemcitabine chemotherapy alone from the first cohort, more tumor cell PD-L1 reduction was observed compared to other cohorts. And we can also say that by adding durvalumab or durvalumab and tremelimumab, more immune cell PD-L1 was increased compared to chemotherapy alone. Even though we couldn't find any statistical difference based on this limited number of paired biopsy sample. But the important finding is that those change of PD-L1 status was quite well correlated with efficacy. For example, patients who showed the tumor cell PD-L1 decrease and the immune cell PD-L1 decrease, those patients did quite poor. So PFS was quite shorter compared to other patients, and overall survival quite poor compared to other patients. Very big difference. And when you look at the immune cell PD-L1 change, like increased immune cell PD-L1, decreased immune cell PD-L1, and no change after just 1 cycle of treatment, you can see big difference in terms of PFS and OS. Quite interesting finding. We also correlated the survival outcome by TMB status. In this analysis, we defined high versus low TMB based on the upper quartile cutoff in each cohort. So the main finding is that even though there's no statistical p-value was absent, but in terms of 2 cohorts, first 2 cohorts, high TMB patients tend to be doing better. Interestingly, cohort number 3, there's no difference according to TMB status. We found a variety number and variety range of genetic alteration in NGS. And we found some association of genetic mutation with survival outcome. Interestingly, ACO2, GEM6 plus durvalumab combination, KRAS mutation, and CDKN2A mutation, ARID1A mutation, TP53 mutation did worse compared to each wild type cohort in terms of progression-free survival and overall survival. But interestingly, when you add tremelimumab on top of this GEM6 plus durvalumab, especially KRAS and ARID1A mutation worse effect was diluted by this addition of tremelimumab. So we cannot draw the very firm conclusion, but I think this finding is a clue for us to move for further study on this kind of the analysis. So based on this phase 2 study, which showed very encouraging efficacy and a very tolerable safety profile, we launched a phase 3 TOPAZ-1 trial. So TOPAZ-1 is a phase 3 randomized, double-blind, placebo-controlled study of durvalumab in combination with gemcitabine and cisplatin in patients with advanced biliary tract cancer. So this TOPAZ-1 is the first global phase 3 study evaluating the concept of immunotherapy and cytotoxic chemotherapy combination as first-line treatment for advanced BTC. This is global study. So in this global map, you can find the involving country and all the investigators across the world. This is study design. It's a double-blind, multi-center global study. Key eligibility criteria included that the patient should have locally advanced or metastatic disease, which included intrahepatic cholangio, extrahepatic cholangio, and gallbladder cancer. So TOPAZ-1 study, we excluded ampullary bladder cancer. The patient should be chemotherapy naive for their unresectable or metastatic disease. And if the disease is recurrent case, that recurrence should be occurred more than 6 months after curative surgery or adjuvant therapy. And the patient had equal performance 0 or 1. The patients were randomized into durvalumab and GEM6 combination arm or placebo plus GEM6 combination arm in a 1-to-1 ratio. In both GEM6 was used up to 8 cycles based on the original ABC02 trial design. And after 8 cycles, durvalumab or placebo monotherapy was continued till disease progression. There are 2 stratification factors. One is disease status, which is initially unresectable versus recurrent case. The second one is primary tumor location. So that is intrahepatic, extrahepatic versus gallbladder. Primary endpoint was overall survival, single primary endpoint. And the secondary endpoints includes progression-free survival, objective response rate, duration of response, and efficacy by PD-L1 status and safety. Because the result for overall survival was statistically significant at the pre-planned interim analysis, the results presented this ASCO GI conference are to be considered the final formal statistical analysis for overall survival. Total 685 patients were enrolled, and 341 patients were randomized into durvalumab arm and 344 into placebo arm. At the time of data cutoff, more patients in durvalumab arm were still receiving treatment. That is 18.6% compared to 5.8% in placebo arm. The main reason of study discontinuation was disease progression in both arms. Interestingly, discontinuation due to adverse event was quite rare in both arms and very similar. For example, 5.8% in durvalumab arm and 5.3% in placebo arm. Interesting. And after discontinuation from TOPAZ-1 study, 42% and 49% of patients in each arm received subsequent anti-cancer therapy, mainly by cytotoxic chemotherapy, both arms. However, in placebo arm, 4.7% of patients received immunotherapy. This is baseline characteristics. The baseline characteristics was quite well balanced between two arms. Median age was 64, half were female, and 54% of patients recruited from Asian country, and the others from rest of the world. Half of patients had equal performance 0, and in terms of primary tumor location, 55% had intrahepatic cholangiocarcinoma, and 19% extrahepatic cholangio, and 25% gallbladder cancer. In terms of disease status, 80% had initially unresectable case and 19% recurrent case. Primary endpoint overall survival data shown here. The overall survival was significantly improved by addition of durvalumab on top of gemcitabine from 11.5 months to 12.8 months median value. The hazard ratio 0.80. The statistical significance cutoff for OSP value was 0.03, and the actual p-value was 0.021. The total hazard ratio was 0.80, as I mentioned. The hazard ratio from randomization for time up to 6 months was 0.91. However, hazard ratio for time after 6 months was 0.74. So the survival curve began to separate around 6 months after, and the difference between two curves became to be bigger and bigger as time went on. So absolute difference in survival rate at 1 year and 1.5 years and 2 years was 6%, 10%, and 15% respectively. And interestingly, 2 year survival rate in durvalumab arm was 24.9%. When you look at the subgroup analysis data of overall survival, we could say that all patients got the benefit by adding durvalumab in terms of overall survival. And the overall survival analysis according to PD-L1 expression, we can say that the durvalumab benefit was observed across PD-L1 expression status. The progression-free survival was also improved by addition of durvalumab from 5.7 months to 7.2 months median value. The hazard ratio was 0.75, p-value was 0.001. The absolute difference in PFS rate at 6 months, and 9 months, and 12 months was 11%, 10%, and 10% respectively. And this PFS curve began to separate around 4 months. ORR was also improved from 18.7% placebo arm to 26.7% in durvalumab arm, which included 2.1% CR case in durvalumab arm. And median time to response was also shorter and quicker in durvalumab arm, 1.6 months, compared to 2.7 months in placebo arm. And more patients in durvalumab arm remained response more than 9 months and more than 12 months. This is treatment exposure data. And in terms of adverse event, any AE or any TRAE was quite similar between two arms. And any grade 3/4 AE and TRAE also quite similar between two arms. Any serious adverse event, any serious TRAE is also quite similar between two arms. And even Any AE or TRAE leading to study discontinuation was lower in durvalumab. And majority of grade 3-4 adverse events were hematologic toxicity. But again, the frequency was quite similar between two arms. Immune-mediated adverse events were observed in 12.7% in durvalumab, all grade immune-mediated adverse event, and 4.7% in placebo arm. However, grade 3-4 immune-mediated adverse events were quite rarely observed even in durvalumab arm. So, in conclusion, TOPAZ-1 is the first global phase 3 study to report a positive result testing immunotherapy and cytotoxic chemotherapy combination as first-line treatment for advanced BTC. TOPAZ-1 met its primary endpoint at the pre-planned interim analysis. Durvalumab plus Gemcis demonstrated statistically significant and clinically meaningful prolonged overall survival compared with placebo plus Gemcis. Furthermore, Gemcis did not add additional toxicity to that observed with Gemcis, and no new safety signals were identified from the known safety profile of each individual treatment. So, durvalumab plus Gemcis is an effective first-line therapy and could become a new standard of care for patients with advanced biliary tract cancer. Thank you for your attention. Thank you.